So, we're talking about heart, we're talking about kidneys, and so it's natural to also have to talk about fluids and electrolytes. We've kind of already covered with the kidneys, right? So, when we talk about fluid and electrolytes, we always refer to the tonicity or osmolality. Okay, those either one of those might be terms that you might be have heard before. Okay, so we have three. We have isotonic, which means the same concentration of non-penetrating solutes as found in cells. Like what did you say? Isotonic, same concentration. Hypotonic, lower concentration. Hypertonic, higher concentration. What am I talking about? Okay. So in reference to the cell, okay, that's what I'm referring to. In reference to the cell, we have hypertonic, okay, needs to increase. We have isotonic, okay, which is equal to, and then we have hypotonic, which is a decrease, okay, and we're referring to the concentration. So what does this mean? If we have, let me get another color. We have our blood vessel, okay? We also have our cells around it, okay? When we have our cells, right, because how do we know if we're dehydrated? How do we know if we have fluid excess? How do we know when we're okay, right? Each one of you guys will have a totally different answer. What are signs and symptoms of dehydration?
Headache,
Dry mouth,
urine,
headaches.
urine,
What about the urine?
yellow,
More concentrated and less output, right? And those are real basic, real fast, like you know for the day you're dehydrated, right? But what about long term? Confusion, fatigue, dizzy. What else? What do your lips look like after a couple days? Cracked and dry and shriveled, right? Well, guess what? That's what our cell looks like. Okay, that's what our cell looks like. If we have a higher concentration, just like we said, think about your kidneys. There's a higher concentration and less amount of water, right? When we're peeing and we're dehydrated. In and out.
Like the proteins and stuff or whatever?
Not necessarily. Not necessarily. I'm not gonna get that crazy into it because it's gonna confuse everyone. I'm making it simple. So when you are dehydrated, okay, things shrivel, right? Mouth shrivels, increased concentration of electrolytes and all of those things within your bloodstream. Your cell is small, right? Think of it, small and shriveled, okay? If it's isotonic, all is good and well, like you and me right now, does anything change with our cell? Our cell is the optimal size, right? Okay, so our cell is this big and it's happy. Hypotonic, we have too much fluid. What is your cell gonna look like? It's a big boy, right? That's a big boy. Hypo, hippo. Okay, in reference to the cell, when you're talking about what the cell looks like, hypo, hippo. Cell is large, fluid overloaded, okay? Isotonic is equal, all is well in the world, alright? Hypertonic, you're dehydrated. Small, shriveled. Okay? In both of these, you can have neurological changes. In both of them, you'll have cardiovascular changes. Okay? So it'll affect it each way, but how it affects it will be slightly different. Okay? But if it's not normal, something's bound to happen. Okay? So just remember, in reference to the cell, not your blood vessels, not the tissue, not nothing, in reference to the cell, what the cell looks like in these fluid hydration statuses, hypo is hippo, large cell. Okay? Did anyone miss that? So if hypo is hippo, it's only natural that hyper is gonna be the opposite of that, right? And iso is fine, right? It's where it's supposed to be. So remember one, you remember the other one. Alright? So this has to do with the tonicity. I could go into all day and go into chemistry and the solutes and the solubility and blah blah blah, and everyone always gets screws up with that, right? Osmosis versus diffusion. Everyone's like, wait, which one is it? I'm not getting into that. Reference the cell. Hypertonic, small and shriveled. Isotonic, all is well in the world. Hypotonic is your hippo. Okay? Too much water. Now, when we have this, right? Everyone's heard of IVs, everyone's heard of IV fluids. There's a lot of different types of IV fluids. Okay? When we give something IV, where is it entering? Bloodstream directly, right? Our vascular space. And for the most part, it stays there unless we got other issues, which happens all the time. So, the biggest one that we use at the hospital is what we refer to as normal saline, or NS, for short of normal saline. That has, the chemical name, right, is the 0.9% saline. That gives the osmolality and tonicity of the norm. Okay? So we're gonna add this one. Okay? So we refer to the isotonic. We're gonna refer to this as 0.9%. Okay? Normal saline. NS. Now, what we call D5W is a little bit of sugar, 5% sugar in water. It's technically in the bag. It is hypertonic because dextrose, right, glucose is large molecules. But once you put it in IV, it becomes isotonic because your body gets sucks up the glucose. Okay, you'll get that in nursing school. Have fun with it.
Is the D5 and the Ringer's the exact same thing?
And LR, no, totally different. Totally different.
So that's hyper.
In the bag, it's hypertonic. Most of the time, anything with any glucose is hypertonic because it's more higher concentration. But this one specifically, there's a lot of controversy. You could see it on an isotonic solution, under an isotonic solution. You could see it under a hypertonic solution. If you get the physical bag, it'll say it's a hypertonic solution. However, once you infuse it intravascularly, the D5, it's a very small amount, 5%, right, of the whole bag glucose. It gets absorbed very quickly, so you're left really with water, which is isotonic, okay? Then we have what we refer to as LR, or lactated ringers, and that one is also isotonic, but the components are a little different. It has some electrolytes and things in there. So most of the time, the biggest place we use that is for burn and for OR. So would I want to give these to a patient with hypertension?
Which one?
Any of them? Do I want to give any isotonic solutions to my patient with hypertension?
Yes.
Why?
Because if they're hypertensive, maybe they have like high sodium in their blood, so you want to dilute sodium into their blood.
So this wouldn't dilute, right? It'd keep it exactly the same concentration because it's isotonic. So, yeah, no, right? They're already fluid overloaded. You don't want to give them more. Hypertension, cardiac, same thing. renal disease, right? Same idea behind there. You don't wanna give too many solutions, to these patients. If anything, you're telling them to reduce the amount of fluids they're intaking, okay? So then we have hypotonic solutions. Again, enters a vascular space, but then we have shifting happen, right? So things are either going into the cell to make it larger or out of the cell to make it shrink. And it depends on whether it's a hypertonic solution or a hypotonic solution, okay? So, if we have a hypotonic, what does it make the cell do? What does my cell look like? Yeah, hippo, right? Nice and big. So where is the fluid shifting? Into the cell, right? Perfect, okay? So it's coming from the blood, because that's where I'm putting the fluid, but the fluid's like, hey, I need to go somewhere, right? I can't put all that in the vascular space, it's gotta go. So it's going to bring that, and it's gonna go into, that fluid is gonna go into the cell, which is why it makes it large and hippo, right? So when would I give that type of medication, a hypotonic solution? Person who's dehydrated, right? If they're dehydrated and I need to give them some fluids, someone who maybe has had diarrhea for a couple days or nausea and vomiting for a couple of days that's dehydrated, might wanna give them some of these. Okay, so some examples are, notice again, how much saline? Is this less or higher than the isotonic? It's less, right? So it's half. It's half normal saline, right? 0.45 times 2 is 0.9, so it's less. 0.225, which is half of that, also hypotonic, 0.33, all less than 0.9, okay? So all of those are examples of hypotonic solutions. So if you give any of these, we're expecting our cells to look like a hippo, right? Get larger. But if I continue to give this to this person, what ends up happening to them? What if I give too much? Right? Yes. Then I can actually cause fluid overload. Then we have the opposite, hypertonic, right? So volume expanders, we refer to this as volume expanders. So if we have third spacing, like the ascites, or cerebral edema, or burns, again, we'll use these fluids, okay? These are very rarely given. If you give these, they're in an ICU setting, critical care setting. And the biggest one that we give that's very critical, I've never seen 5NS given, but we have 3%. And is 3% bigger than 0.9%? Yes. Heck yeah, right? That's a huge amount of sodium. So if someone comes in and their sodium is, the normal's 135 to 145. If they come in and their sodium's 120, would I be giving them 3% to replace their sodium? Heck yeah, I would, right? It's really low, so we would give it, to increase it. If they come in and their sodium supposed to be 135 to 145 and it's 155, should I be giving them 3%? No, right? You have your D10s, those are hyper, right, has large molecules. D5 and normal saline, okay, so normal saline is isotonic and I'm adding these larger ones into it. Is it hyper or hypo? Hyper, right, it's creating a larger concentration. D5, like I said, you add D5 to anything isotonic, it makes it hypertonic, okay? You do not need to memorize the fluids, okay? I want you to really have this down. Iso versus hyper versus hypo, what the cell looks like, what my patient would look like if they were in those, if my patient was hypertonic or hypotonic. Now think about it. If I have a hypotonic patient, what would my blood pressure look like for that patient? I have increase. Think about the shift. Hypo. If I have hypotonic, what does my patient's blood pressure look like? So we got everyone's on the high boat?
Lower.
Huh?
Lower.
Why do you say lower?
Because of the amount of fluid within the cells, making you, I don't know.
She's like,
I'm like trying to figure it out in my
It's
own.
probably less, it's like less, I would say it's lower because it's less stuff that has to push, like if it was like tomato sauce, being hypertonic.
Oh, okay.
And then when it's lower, it's more fluid, it just shouldn't like scratch or touch anything on the blood vessels, just kind of smoothly going through.
Okay. So let's think back to the video we watched about blood pressure, right? Where do we take blood pressure? What are we testing to get the blood pressure? Okay, think small, y'all. Not asking something huge. What system? Circulatory, which is represented by what on here? The blood, okay? So, if in a hypotonic, my fluid is coming out from there and coming into the cell, is my blood pressure gonna be higher or lower? Huh? Lower, because my cells are larger, the fluid that I have in my cardiovascular system are going into my cells, so it's depleting what I have in my vascular space, right?
Would it make the cells fatter?
Yeah, the cells are fat,
Yeah.
but that's not in my cells, right, are not in my bloodstream. So this ends up decreasing, so it's the opposite. You think large cells, guess what? The shift is causing low in the bloodstream because that's where it's coming from, right? So it's actually decreasing the blood pressure. So you can have a patient that's this big and swollen that looks like that chick that ate the blueberry thing on the chocolate factory.
Violet.
That has, Violet, that has super low blood pressure and you're kinda like, what the heck? What's going on here? Like, why do they have what you think they have? High blood pressure, right? Then you know that there's a hypotonic shift, okay? So for this patient, I would have a decrease in blood pressure, right? Because all the fluid is going out from the blood, which is where I get my pressure readings into the cells, okay? So what about my isotonic patient? What would their blood pressure be like? Normal, right? Normal BP. What about hypertonic? High. Yeah. They can have high blood pressure. Because that fluid is coming from the cell into the blood. No, shriveling the cell in the blood,
Yeah, making the blood
but
like.
is actually volume expanding. Yeah. Right?
Somebody who's dehydrated, are they hypertonic? Does that have anything to do with dehydration and hypertonic?
Yes, this is your hydration, this could tell you what your hydration status is for your patient. So, if you take a blood pressure, the patient looks swollen, you think, oh, they got fluid overload, yes, but where is the fluid? The fluid is in the cells, right?
Not in the blood?
Not in the bloodstream, so you're kinda like, crap, you take a blood pressure and it's low, and you're thinking like, nah, it's gotta be high, they're huge. Well, guess what, they could be cardiovascularly depleted, and interstitial fluid right in and around the cell could be, have a lot. That's where you get your edema from. That's what's happening with edema.
Oh.
So, but edema though can get really bad to where, like we talked about with CHF, it can end up flowing everywhere. So all that fluid that we're pumping into the patient is just going everywhere else, and not staying in that cardiovascular system, so it can cause issues.
And then when they're hypertonic and if they're dehydrated, the blood pressure can go up because the body's trying to compensate for,
No,
No?
because the fluid is leaving the cell and going into the blood, so it's the opposite.
Oh,
Your cells
okay.
are tiny, but all of your fluid is in your blood, your cardiovascular system, because of the shift.
oh, so then the cardiovascular system has a larger amount of blood,
Yes.
which, like in the video.
Increases your
Oh,
blood pressure,
okay.
because again, where we take the blood pressure reading
Uh-huh.
is your cardiovascular system.
Oh, okay.
So depending
That
on
makes
how much
sense.
is or is not in your cardiovascular system will depend on what your blood pressure is. Most people, like, they see me and they're like, okay, she's a larger girl. She's probably has hypertension or something like that. You would assume that. And actually, I just got it done 2 days ago for physical, and my heart rate was 51, and my blood pressure was like 90 something over whatever. And that's normal for me. That's always low. Actually, the 51, I was pretty damn exhausted. I've never seen it that low, but I was like, it's okay. I'm just gonna die. Cause she was like, I think I need a retake. I said, no, I haven't slept for a couple days. It's real. But you would see that. So, point is, just by looking at someone, you really can't tell whether the person is healthy or not. People would assume I'm super, like my husband, he's slender, small, typical Filipino, shorter, midget. And you would think, just by looking at us, like, oh, she's the cow, he's not. He must eat and exercise real well, and I can outrun him any day. And his kids, actually. And you would think that. Then you look at our labs, he was so pissed when he saw our labs together. He was like, how is that? And I was like, are you calling me fat? What are you trying to say? He's like, well, I would just think that. And I was like, he was on the couch. So with something like that, don't always take for granted that you know. Always take your subjective data along with your objective data. Okay? I see nurses do that all the time, and patients will die because of it. Because you're making assumptions instead of looking at the actual patient and wondering what's going on, what's really happening with this patient. Okay? So this is the basis of what I really want you to know. Okay? Is ISO versus hyper and hypo. The real only ones that'll help you really to memorize this is gonna be your 0.9% NS, anything below that, anything above, and what your patient would look like, where these shifts of fluid are happening, okay? Does that, and that's why for this one you need really close monitoring, not only because of really quick shifts, but think about it, if this is happening in your brain cells, you can get signs and symptoms of toxicity for either hyper or hypo really quick, right? Because imagine your brain, you have your cranium, right, your skull. Is there a lot of space for error? No. So just neurologically, if I start giving a hypotonic solution, what's gonna happen in my brain? My brain cells are gonna do what? Swell, right? And at some point, if it swells, and I've got neurological issues and things like that, it can only swell so much before it starts coming out the back. That's called herniating, and then you die. If I have the opposite happening, right, where the cells are shrinking, but I'm like, oh, their blood pressure is great, because I'm only looking at the monitor and not at my patient, right, and what signs and symptoms they might be having. I'm like, oh yeah, blood pressure's great, and they're like confused and combative and all this stuff, and you're like, wow, they're going crazy, whatever. You have to link this craziness might actually be to a shift or something going on with your patient that could end up killing them. So even if your cells, right, brain cells shrink, that's not good either. That's not good either. So obviously your beautiful space is isotonic. But that's assuming you can still give isotonic fluids and kill your patient. That's assuming in a healthy patient that they'll know that it's too much sodium and they excrete it through their kidneys, it's too much water, they excrete it and increase urine. But if I have a patient in renal failure and I'm giving them isotonic fluids, can I still kill them? Yes, they're not excreting it. Their sensors are not the same as ours. They're already reabsorbing sodium and I'm giving them, although it's a low concentration, I'm still giving them more sodium, right? So I can still increase all of those things and it's not a happy place, okay? So if I said you have a patient, they're in chronic renal failure and you're giving isotonic fluids, what would you wanna be weary of? What signs and symptoms would you wanna look for, right? If they have any type of edema, whether it be peripheral, maybe it's pulmonary, they're coughing a lot, or they have a lot of sputum, that's too much fluid, if they're having shortness of breath, things like that. Those are things you're gonna wanna start thinking about, especially because I know probably like a quarter to half of you guys already submitted your applications, right? For the nursing program? She's like, hell yeah, I did. Right, so those are the things, that's the train of thought you're gonna start having, is what is it gonna look like in my patient? Okay? So, isotonic fluids cause shifting of water from the extracellular space to the intracellular cellular space. True or false? Well, what's extracellular space?
The stuff outside of the cell.
Which includes,
Blood.
yeah, right? And intracellular space, inside the cell, right? So can isotonic fluids cause a shift of water from extracellular, from the bloodstream, to intracellular?
Yes.
No.
If
Yeah,
it's
I guess
normal.
so.
It's non-penetrating, right?
If it's shriveled.
It can?
Yeah,
More fluids inside the cell than it can.
Yes.
Yeah, the concentration.
exactly, right? Me and you do that all the time. We feel a little dehydrated, we get a little isotonic solution, and we want it to move back into that
I
cell,
thought it was
right? So just
non-penetrating.
to hydrate it, just to hydrate it. So yes, it can, but when we talk about, for you to easily remember this, just memorize it that way. But know that yes, isotonic will cause a shift, but all it does is equalize. So if my cell is small, but it's really supposed to be this size, is that isotonic fluid gonna move in there? Hell yeah, that's what we want it to do, right? Absolutely. So, it depends on the degree of the hypertonicity of the patient when we'll use either an isotonic solution or a, hypotonic solution.
But say you have, somebody who you think is dehydrated, like say they're diabetic and well, they would still be dehydrated, right? If they're like diabetic and their sugar levels are crazy high.
It's not that they're dehydrated,
Okay.
it's just that the concentration
Making
has
them all-
changed, right? Now I have a high amount of glucose and I
Yeah.
need to dilute that.
Yeah, so you wouldn't give, like, if you just assumed and you say didn't take their blood sugar and you gave them isotonic solution.
We do, we give them
Okay.
500 mLs
That's
an hour
okay.
if they're DKA.
Okay.
Mhm.
Cause I was like.
Because
well,
we need to bring down that ratio. We need to bring down that ratio.
Okay.
But we're also doing other things like
Right.
giving them insulin and all that stuff. We're not
Mhm.
just giving them isotonic solution.
Okay.
But yes, the shift will happen if you're not already normal, right? If your cell is happy and your blood pressure is fabulous, then it's just gonna be an equalizing. And what's your kidneys gonna do with that when you intake more water?
You know,
You're gonna feed the excess, right? But then I have this little shriveled cell, and I have my cardiovascular system, I drink some isotonic solution. Where's that isotonic solution gonna go? Until it makes it normal, right? Until it makes it normal. Then I have this this huge cell, and I'm giving them isotonic. What's happening there? It will actually most likely pull out, but it's not, it would be really slow for that to happen. So many times we just say to stop with the water, and then your body will get rid of it by itself. If not, we can give them a
You're right.
think about before this,
Diuretic.
diuretic. Yes, we can give them a diuretic. Okay. Do you see how it all kind of comes in a circle?
Yes.
People are like, yeah, I don't know about that. Okay, they all relate to each other. They all relate to each other. Okay? I'm not gonna get into that. This is just a neat little chart, I would say, to say for when you guys go into your nursing program. D5 in water, see? So isotonic becomes hypotonic as it metabolizes, blah, blah, blah. And all of it has to do, with what it's made up of, okay? That's a damn answer. But which solution is not a hypertonic solution? So is D5 normal saline a hypertonic? What's 0.9%? Normal saline. That's isotonic, right? Then I add D5 on top of it, it makes it hypertonic. 5% saline. Hyper, right? That's a lot of saline. Then LR, what's LR? Iso, hyper, or hypo? Isotonic, then I add D5 on top of it, makes it hyper. 0.33% normal saline is the hypo, right? Okay. Oh, do I really wanna do this? Let's move into hypertension. I think acid base will be too much for you guys today. Okay.
So does that mean we're coming back into it, or we're just not gonna?
We might, but it would probably be with endocrine. Cause that's a huge thing that our kidney does too, is acid base balance, huge between that and our respiratory system. But, we've gone over a lot today, and you're gonna get a bunch of notes right now. So, hypertension. You know what, before we get into this, go take one more walk around, go back, jog your, all your good hormones.
Did you know there's turtles over there? Yeah.
Let's go, yeah, jog around.
I just kept looking, I'm like, oh my god, if that water's not moving, there's mosquitoes.
Oh yeah.
They're so cool.
Just remind me to turn this